Good evening, everyone. Thank you for coming on such a chilly evening. And it's actually, I'm very pleased to see that it was even difficult to find a parking spot in this library. So it means that our libraries are alive and well, which is very nice. So I am tonight, in our short amount of time, what I'd like to do with this is, as Ross said, there's very little knowledge about urinary incontinence, but it's become a field that's more and more important as the population starts getting into an older age group, and we are seeing more and more of this. And many of us actually have to care for both young and elderly relatives with this condition. So over the past 10 years, the government and the research community has actually started to take notice of this and has actually poured in some money and emphasis on research in this area. So much to the point that now we are actually having a very effective treatments for people, and we really would like to get this out into the community so that people can really benefit from this. And what I thought I would do in the next 40 minutes is summarize what we understand generally about urinary incontinence in females, and also some of the treatments that we can offer to you so that you can have a general view of what's available out there at the moment. What I'd like to do also is perhaps leave the questions towards the end, and so that we can actually finish the talk up front. Okay? Great. So when we talk about urinary incontinence, it's actually a pretty easy definition. The International Continence Society, the ICS, actually has defined it as the involuntary loss of urine that becomes a hygienic or social problem to the individual. It's fairly common for most people to lose a tiny, tiny bit of urine every now and then when they have a big cough or sneeze. That's actually within the normal limits, and that generally does not present a hygienic or social problem. But in some individuals, when it gets to a point where they're soiling their clothes, or the bed constantly is getting wet, or their skin conditions, then it becomes what we call quality of life condition, urinary incontinence. So for decades, until roughly 10, 20 years ago, this problem was actually not addressed by the medical community. So much that patients actually themselves did not bring it to the attention of their doctors, because it was really felt by many people that, oh, it's just part of getting old. It's just part of being a female. And it's normal after childbirth, because most women will develop some level of urinary loss after having vaginal childbirth. So nobody talked about it. Physicians generally didn't think it was a problem. And so it went for many, many decades without being addressed. Now, it came to our attention actually in the past 20 years, because surveys started to come out, and we started realizing that actually many Americans actually suffer from incontinence. Statistically, the surveys indicate to us that over 25 million of Americans actually suffer from incontinence. When you calculate the cost of to society, the cost of urinary incontinence is about over $20 billion. Because what happens is that not only does the incontinence cause problems with time away from work, you have surgeries that go into treating this condition. You have some patients get institutionalized because they're incontinent. And then you have a whole array of products that are being used for incontinence. Diapers, pads, cleaning solutions, things of that sort. When you add everything up, it tallies up to more than $20 billion, which is tremendous. And that's really what has prompted the government to start paying more attention into this area. And unfortunately, in spite of this many people suffering from this, only 1 in 4 women to this day seek treatment. And again, because I think we're still fairly young field, and we're not people don't know that there's treatment, and hence we have this type of talks to try to get this out into the community. If you look at how much it affects people, 1/3 of women under age 65 actually have incontinence, and It becomes a little bit higher in the postmenopausal female population. But when you go and look at the long-term care facilities, like the assisted living facilities, greater than 50% of women actually have it. In fact, urinary incontinence is one of the primary reasons for families to have to institutionalize their elderly parents, which is a big, big problem. Generally, it's because they can't take care of the incontinence themselves because the younger family members are working and they don't have the means to care for the incontinence. So if you look at how this is distributed, because I don't want people to walk away thinking that urinary incontinence is only in females. It happens to men too. But in men, the distribution is slightly different than women. If you look at the age group under 64, usually men don't have urinary incontinence. It's fairly rare. But after age 60, the percentage of men having urinary incontinence increases to around 10 to 15%. And that's because after that age, they start having prostate problems. And prostate problems then lead to surgery, which causes injury to those tissues, and the incontinence can ensue from that. Okay, so just to give you an idea what this $20 billion mean per year, it's actually more dollars than what the US actually spends on breast cancer treatment or arthritis. You look at your friends, many of them have arthritis, and you would think that that's something that's very, very costly to our society. But urinary incontinence is in the range of what this country spends for arthritis and also for breast cancer. So it is really getting up there. And another indicator that is becoming a more common problem is the sales of adult diapers. In 1989, the sales of adult diapers was like 492 million, but within 5 years, it went up to 1 billion. And I don't have the recent figures, but it's really skyrocketing. And here again, we don't hear about this because luckily with the internet era, many of our elderly patients can order online, so it gets mail shipped to their homes directly, so you don't see people buying them in the supermarkets in large quantities. So it's fairly hidden. But Johnson & Johnson, these companies that make these diapers have actually very good statistics that indicate that the sales is actually increasing with the baby boomer population getting older. Okay. So just to shift gears a little bit, let me talk a little bit about what makes us all continent, meaning that how is it that we can go about exercising, jogging, and not leak all the time. The continence mechanism in your body is really quite complex. It's not just one single organ that has to function well. It's a combination of different types of tissues and organs. So first of all, you have a urethral sphincter. So if you can envision, the bladder is basically a big bag that its only purpose is to store urine that's coming from your kidneys. But in order to store the urine, it has to be very tight. It has to be, the seal has to be very tight so that the urine is not constantly leaking out. So there is a urethral sphincter, a muscle that actually keeps it closed, so tight that it doesn't leak. There's also endopelvic fascia, which is the fascia, the ligaments that actually hold up this entire structure, because it has to keep it within your abdomen rather than sagging out so that it can be contained. It also has muscles that need to work so that when you want to urinate, the muscles can relax, and certain muscles have to work to squeeze the urine out. The way you urinate is not dependent on gravity. A lot of people would like to think, okay, we sit on the toilet or we stand at the urinal and the gravity just kind of pulls the urine out. But actually the bladder has a set of muscles that actually squeezes the urine out actively. And that is what allows astronauts to be able to urinate, because in space there's no gravity. So you can't stand at a urinal and say, well, okay, let gravity do its job. So we do have a system within our body that pushes the urine out. So this muscle has to work really well. And lastly, the nerve has to tell the muscle, okay, it's time to squeeze, it's time to relax and open up the faucet so that it can come out. And that nerve travels all the way from the brain, which is the central command, goes down the spinal cord all the way down to the bladder. So if there's any problem in this entire pathway, the bladder will see the effect. So the whole mechanism is really very complex. Okay, so just to kind of give you a visual idea of how this mechanism is all put together, I'm just going to show you a little anatomy. So this is kind of the pelvic bone. This is our hip bone. And we're looking down from the head down, and here these are the legs, the bones of the legs. And if you look at this, this is the urethra, which is the little tube that connects the bladder to the outside. The bladder will sit in this area, and these white little fibrous things are the connective tissue that actually lifts the bladder up, keeps it in position. So that those fibers have to be strong and not ripped or not damaged, so that the bladder can remain in a good position for it to function. Okay, so additionally, in this pelvis, in the bone, here's the vagina that's here, and here's the urethra. You see that there are nerves that come to the muscle that keeps the opening of the bladder closed. And here are the fibers that support it, so that the muscle is constantly getting the message from the brain. Okay, stay shut, don't leak, don't open up. So, but however, when you have a surgery in this area, or if you have childbirth, these nerves are so close to the area where the baby's head is coming down or where the surgery is being performed, it's not uncommon for these nerves to be damaged, so that later on in life, the muscle of the bladder doesn't work very well. So the things that predispose somebody to have urinary incontinence are, of course, as we look at the anatomy, the number one factor is vaginal childbirth. And that's over time and time again. We see that women who have big babies, very difficult deliveries where they have to have forceps and there's lots of tears, or if they have multiple babies, they have a higher risk of having urinary incontinence as they get older. Another risk factor is aging. Aging alone itself can also predispose somebody to incontinence. And the reason for that, we don't know completely, but we believe that as people age, the muscle fibers weaken, and also some of them will actually die. And this is the reason why if you look at Mr. Universe when he was 20, they look really, really big. But then when you take the same person and look at them, 50 years down the road, they're still muscular, but the muscle has really shrunken and thinned down. So the muscle that helps close the bladder undergoes the same thing. The number of muscle fibers actually decrease. So that's why the seal is not so tight. Now, obesity also can be a factor because what happens is that if you gain weight, a lot of the fat resides kind of in your torso, and it pushes down on the bladder, so it provides extra weight that is pushing constantly. So if you are jogging or sneezing, in addition to that force, you also have the weight of the intestines that are pushing on that system. And we know there's very good research that show that if people are put on a diet, and if they lose 5 to 15 pounds, they can make a big difference in their incontinence symptoms, which is something that we can all do. There are also genetic factors that predispose people to this. There are families that have urinary leakage that we know of, but we haven't actually to this day been able to isolate a specific gene or a family of genes that correspond to this. So the reason why we know that there are genetic factors is from like family histories, clusters of families that have incontinence, and also from racial differences that we've been able to capture over the past decade. Because we see that Caucasian people tend to have more incontinence that's related to activity compared to African Americans or Hispanics. So there's probably some racial genetic issues. And lastly, as I said before, if somebody has a lot of pelvic surgeries, the nerves and muscles in that area can be damaged from that. So the more surgeries you have in your pelvis, the more likely you will be at having incontinence. And that's the primary mechanism by which men have incontinence, because of prostate surgery. Okay, so there are two different main categories for urinary incontinence. So that, and I bring this out because it's actually, it would be good for you to understand the kind of language that we use, so that when you speak to your doctors, if these terms are being thrown out at you, you can have some understanding as to what they're talking about. One category of urinary incontinence is called stress incontinence. And that doesn't mean that the system is under stress or very, very anxious or anything like that. It means that the bladder is being pushed by some force. So it's a stress load. For example, when you're sneezing, you're pushing down onto the bladder. Or when you're jogging, there's a force that goes down. So the bladder leaks when there's this kind of force. So that's leaking with cough, sneezing, exercise, or any kind of activity. Then the other big category falls under the overactive bladder category. And in that category, we're talking about patients who leak when they have a lot of urgency. They feel like, oh, I gotta go to the bathroom, but they can't quite make it to the bathroom before they leak. No matter how hard they try, they run to the bathroom, but before they sit on the toilet, it's already, everything is kind of out and there's a big puddle. Within this category, we also see patients very often will have frequency, urgency, and nocturia, meaning that they're getting up a lot at night, 3 or 4 times at night, such that they're unable to sleep well, and the next day they're just exhausted from constantly being up. So this is how we generally separate the incontinence symptoms. And you probably have seen TV ads for overactive bladder. That's what they're talking about, okay? And the reason why we have traditionally separated these into these two big groups is that for a long, long time, we didn't understand what caused these kinds of symptoms. So we just categorized things kind of based on kind of the symptomatology. And to this date, we don't have very good understanding of what causes overactive bladder. We're still studying, there's intense research being done on this to try to figure it out, but we don't have a clear idea. So this is just to illustrate the stress incontinence. So what happens is that here's your bladder sitting here. When the woman is coughing, the diaphragm muscles up here exert a big, big force down onto this, presses it. And you can see that if the muscles down here aren't closing very well, then the leakage occurs. And that's stress incontinence, okay? And stress incontinence is primarily due to damage from vaginal birth because the muscles and the ligaments are destroyed. You have the aging and the genetics. And what happens in vaginal birth is that as the baby's head comes down through this area, and here is the muscle of the bladder that closes the bladder, see how the head is actually basically compressing it onto the bone. And if the delivery is so slow, it's basically being macerated against the bone. And over time, you can see why the muscle and the nerve gets crushed and damaged, essentially. Yeah, and this is another picture. You see the baby's head coming down, and see the ligaments and muscles are ripped. And again, in addition to the muscles being crushed and damaged, the ligaments, these white fibers I was showing you that support the urethra, are also being ripped, so that the muscle, in addition to having dead fibers, is unstable, so that when you cough, it's doing a lot of moving and it cannot close very well. So what ends up happening is that this is the bladder and here's the urethra. The muscle here is damaged, and the ligaments that support this wall to keep it nice and closed are loose, and so that when somebody coughs, this whole area opens and the urine comes out. Okay? Now, in addition to, so that's one thing that's happening to the urinary system. But in addition to that, there are organs that are nearby, such as the vagina and the uterus, that are almost attached to the bladder. So if those organs are undergoing some sort of problem or pulling on the bladder, you can see why the urinary system would not work appropriately. So I'm going to talk a little bit about pelvic floor defects because they come so hand in hand that if you just look at the bladder by itself and treated it, you're going to end up having problems in other parts of the pelvis in most females. So when we talk about urinary incontinence in females, we always have to look at the surrounding organs to make sure that we treat everything as a whole unit, so that we don't treat a problem and cause another one somewhere else. And I'm going to explain to you why in a second, show you. So with the childbirth and aging, the ligaments get destroyed, and you can see that, so here's the urethra, and we're looking at the vagina, the vaginal opening. The wall of the vagina here gets so stretched out that it kind of bulges out. When that happens, the bladder loses its support, and so the bladder, rather than being in an upright position, it kind of starts to bend backwards. And when it bends backwards, it's very difficult for it to empty, because you think about urine liquid having to go uphill and then down to be evacuated is very difficult. So if a physician is not aware that there is this condition when treating somebody with a urinary problem, then the person will be half treated after surgery or whatever it is that they decide. So this problem has to be treated concurrently. And in extreme cases, where you can see, this is a picture of a woman here, the buttocks, and here's the clitoris. This is the vaginal opening. The loss of ligament support has been so severe that the vagina is turned inside out, and the uterus has fallen outside of the body. And because the bladder is attached to the uterus, the bladder now is dragged all the way out within this vagina. And here's a picture of that, more like a cartoon. You can see that the uterus is here, and the bladder is, because it's somewhat attached to the uterus, it's kind of folded back down, and so that the urine is trapped in this area. And when it's trapped in that area, it can't empty well, and what can happen ultimately is that the patients can have frequent bladder infections because the urine is not being evacuated. Oftentimes, I have patients coming to me with a complaint, not of incontinence, but of recurrent bladder infections. And when I do a good pelvic exam, I see this situation. And so in that case, what we have to do, it's not that that there's anything wrong with the bladder. What it is this prolapsed uterus. And we have to take care of the prolapsed uterus and lift the bladder up. And once we restore the normal anatomy of the bladder and the nearby organs, then the bladder will be working normally. So the female anatomy is a little bit different than men. So when we treat female incontinence, we also have to take in mind the surrounding organs. Okay, and that's, so what we just talked about are things that are related to anatomical issues. Let me talk a little bit about overactive bladder symptoms, which is the other big category of urinary problems. And this is the category that has the urgency, the frequency, the getting up at night type of thing. What are the things that cause that? The causes are multiple, actually. It can range from multiple infections that causes the bladder to be irritated. That's why you feel this urgency and kind of discomfort. It could be bladder stones. Oftentimes, a high intake of caffeine or can do that. Caffeine is an irritant to the bladder, so it causes people to be having frequency. Diuretics also. Many patients are put on diuretics for their high blood pressure treatment, and the diuretics make you want to urinate frequently. And if that's the primary thing that we find in patients, we actually will work with the internist to try to find them different hypertensive medications to try to get them off of the diuretics. And that may be all the patient needs to get rid of their problem. Bladder cancer is another thing that can cause bladder irritation. Interstitial cystitis is actually a chronic irritation of the inflammation of the bladder that exists. You can get a urethral diverticulum, which is like a little outpouching of the bladder wall, a weakness of the bladder wall. It's extremely rare, so I don't think that would be a big problem in this population. Now, back injury is another common thing that's associated with irritated bladder. And the reason for that is, remember when I talked to you about the nerve connection from the brain all the way down the spine going to the bladder? A lot of people actually have spinal stenosis, or they have bulging discs, or they have sciatica. All those things cause some compromise of this nerve that goes down to the bladder. And if that nerve is irritated, then the bladder will feel it. And I have patients, oftentimes they'll say to me, oh gosh, I don't know why, you know, when my back was bothering me, my bladder symptoms were far worse. And then I had the disc decompression. Now I'm feeling better. So it's probably not that the bladder was wrong, but it was the nerve that was irritated. So that's something too that when I see patients, I try to look at the body as a whole, because the urinary system is not just an isolated system. You have to figure out where are the other things that are contributing. Also, neurological diseases can cause severe bladder symptoms. For example, stroke, again, because you're disrupting the central command, so then they lose control of the bladder. Parkinson's disease, Alzheimer's, multiple sclerosis, all those things are things that actually can cause that. In fact, actually in women, because multiple sclerosis is more common in women, sometimes bladder symptoms are the first presenting sign of multiple sclerosis. And you know, we work these patients up and we follow them for several years, and it's only later on that the multiple sclerosis becomes more evident and declared itself. And there's a big category of unknown causes. We sometimes don't find any reason at all. And in these patients, perhaps there are many hypotheses as to why their bladders are irritated. There are hypotheses such as, oh, the bladder wall proteins are not good, or there's a local inflammation, or the nerves are hypersensitized, or so there's a zillion theories right now, but none of them have concrete evidence that they're correct. Okay, so how do we go about deciding what treatment we should do for these kinds of conditions right now? So first of all, we need to understand that urinary incontinence may have more than just one cause. It's not a simple thing. We have to examine the female pelvis as a whole to make sure that the supportive issues, the muscles, other components are not damaged. And we need to institute the treatment only after complete evaluation has been performed. And when I talk about complete evaluation, depending on the symptoms and how complex the situation is, it could be simple office examination, all the way up to assessing how the muscles are working within the bladder, and actually taking a telescope and looking into the bladder to define the final treatment. But a formal assessment should be done so that we can make sure that the treatment is appropriate. Okay, so once you've had the formal workup, then you can decide on how you want to go about with your treatment. And I'm going to go over conservative treatment and also surgical treatment so that you can kind of get a feel for the range of what we can offer. So for both the stress incontinence type of leakage and the overactive bladder leakage, conservative treatment seems to be of good help. When we talk about conservative treatment, we're talking about behavioral therapy. And I'm going to go over how this is done so that perhaps people can actually start doing them at home or advising their family members and friends how to do them. Generally, behavioral therapy is actually very popular in Europe, in countries where they have very good physical therapy and they have a culture of being more homeopathic than we do in the United States. And so when we look at the studies coming from Europe, we find that they have very high success rates, actually. Most of the patients say that they see a 70% improvement, anywhere from 50 to 90% improvement. So I think there is some merit in that, and so if we were a little bit more motivated, we probably would be able to get to that, and it's worthwhile trying because it's not harmful and there's no side effects. Then when we look at physical, the other category would be physical pelvic floor exercises to try to strengthen these muscles that are weak. Biofeedback to retrain your brain, because if your brain is sending out scrambled messages downwards, you can actually try to retrain them. Pessary is a rubber device. It comes in many different shapes that we actually put into the vagina, and it kind of compresses onto the bladder opening. Sometimes that compression is enough to help prevent the urine from coming out. And then again, weight loss, as we talked about before. So behavioral therapy, one way of doing behavioral therapy is very easy, is what we call the bladder drill. For those people who have like frequency issues, we ask them to, throughout the day, to consciously try to, when they want to go to the bathroom, to try to hold it for an extra 5 minutes. At the beginning, you start with 5 minutes and you work yourself up to a little bit more every day. And throughout the process of maybe 2 to 3 months, you can decrease the number of times you go to the bathroom. Now, when we talk about pelvic floor exercises, what we're doing is, you see this is the bladder with the urethra coming down, and here are the muscles that close the opening, okay? And what you're doing is working on these muscles to contract them continuously. It's almost like a form of a super Kegel. And if you do this every day, many, many times, like 100 or 200 times, then these muscles will get very big. Just like if you worked out your muscles of the arm, they would get very big, and they would be much stronger and help close better. And that has been effective, but it's one of those things that you have to be doing them all the time. If you, after 2 or 3 months of bulking them up, you decide, oh, I'm just too tired, then the muscles will thin down again. Okay, another easy way to do these super Kegels is actually to purchase these vaginal cones. They're like these weighted cones that you put in your vagina. And if your muscles don't tighten up, then they fall out. So you can, a lot of patients wear these at home while they're cooking or, you know, cleaning or whatever, doing yard work for 20 minutes, and that kind of helps the muscles kind of contract. And then you're not kind of having to think about it. Okay, and with biofeedback methodology, this is kind of an old slide. Now we use electronic devices, but it's kind of like, you know, you have an instrument in your vagina and you contract it, and you can see what your muscles are doing so that you can start retraining your brain to contract it when you have a desire of urgency. And this is done actually currently with a physical therapist. You would go with a physical therapist for various sessions. And then it's a kind of a maintenance thing that you do every couple months. And this is the concept of the pessary, where we have the ring kind of sitting here in the vagina right next to the bladder. And you can see that it's compressing this area so that the urine can come out easily. Okay, and this is something that patients kind of learn how to insert and remove themselves, and it's fairly easy. And the pessary comes in all different shapes and forms for the different types of body, because we're clearly all different. And you can see this little nub in here kind of sits right at the opening of the urethra, so it's actually pushing it against the bone and compressing it. And so when we have patients that desire this type of device, we fit it and we try it out for a person, the patient to make sure it's the best fit and most comfortable for them. Okay, so now those are, well, we just talked about the conservative treatment. I'm going to move on to a little bit more kind of invasive type treatments. And the treatments are divided based on the kind of leakage you have, okay? For the overactive bladder, we have a bunch of them, and for incontinence are these. So let's talk a little bit about overactive bladder. And I put them kind of in going from these most conservative all the way down to a slightly experimental, okay? When we have, for what you've seen probably over the last couple years are medications. There's the overactive bladder on TV all the time, you know. So medications are reasonably safe, and they work, but they're not curative. They don't cure you of the condition at all. What they're trying to do is that these medications relax the bladder muscles so that they're not constantly spasming, causing that irritative sensation. So generally what you see with medications is a kind of a lessening of that kind of discomfort. It's not going to eliminate it. It decreases the severity of it. Recently, in the past 2 years, this percutaneous tibial nerve stimulation has come to the forefront and has shown some promise. And what is done there is very interesting, is that it's a small device. It's almost akin to acupuncture. There's a tiny, tiny needle that actually gets put into your tibial nerve kind of near your foot ankle. And there's a little electric current, a little device that dials up the electric current that stimulates that nerve through that needle. Usually you would go for a session. You have this, it's a 30-minute session where the electricity is going in and stimulating the nerve at a small, small rate. And you do that kind of for 12 weeks. And it seems to be effective, but it requires you to go to the doctor's place to have this needle put in and have the treatment applied. So that's something that currently I don't think many insurances are paying, but there are some clinics that do have this facility, and it seems to be effective. I would say probably 50 to 60% of patients will see improvement with this treatment. But it needs kind of a maintenance type thing. Probably every 3 weeks you'll need another session. And the concept is really what you're trying to do is manipulate the nerves. By stimulating this nerve that's on your leg, this nerve actually is connected to some of the nerves in your pelvis. If you stimulate it, you can potentially distract it or cause it to create different sensation in your bladder. A more invasive method to decrease overactive bladder symptoms is the sacral neuromodulation. And it plays along the same kind of philosophy in that what is happening is there you actually put a pacemaker into the nerves of the spine. Okay, and the pacemaker is sending out electrical signals to the spinal nerves, again, to try to redirect the message that's getting into the bladder. And that's a permanent implant into your back. And lastly, for those for the severe contractile bladders where the muscle is just constantly contracting and squeezing the urine out, we do Botox injections, actually, into the bladder. Again, as you know, Botox is used for cosmetics to decrease wrinkles because what it does is it paralyzes the muscle so you can't wrinkle up. If the bladder muscle is too spastic, then we inject this to paralyze that muscle so that it can't spasm. And that's done as it used to be fairly experimental, but I think now some of the insurances are starting to cover that. Okay, for stress incontinence, what we do, there are two things. Stress incontinence, because it's mostly related to damage of the muscles and damage of the ligamentous support of the urinary system, the treatment is more surgical. Okay, we can actually inject bulking agent material to bulk up the muscles to close it better, or we can actually do what we call the sling procedure. I think many of you guys might have heard that, maybe have family members or friends that have had that. And I'm going to show you a picture of that so you can get a better idea of how, where it sits and how it works. Okay, good. So the bulking agent, what we do is, it's actually not a new procedure. The companies would like to sell it as a new thing, but it was actually described in the 1940s. The concept is basically, if you imagine this is the opening of the bladder, it's wide open because the muscle cannot close it. And what is done medically, surgically, is that we actually take a needle and inject material into this area so that it can close better. Okay. What is different now is that there's been many different types of materials that we can inject. So the companies say, oh, we got a new material, a new procedure. But the procedure itself is not that new. Currently, what we are using, up to about 2-3 years ago, we were using collagen, the cosmetic collagen, but that tended to wear off fairly quickly. So currently, there's a new material using calcium particulates that is injected, and hoping that that would last a little longer. The beauty of this procedure is that it's just an injectable, so it's not major surgery. It takes 15 minutes to do in the office, and people can go home. This sling procedure is actually, surprisingly, a fairly new procedure. It was developed by Olmsted in Sweden in the 1990s. It was a very revolutionary procedure, and when it came out, it worked so well that it became the gold standard. Prior to the sling, we had all these very morbid surgeries that required large abdominal incisions, hospital stays for like 3 days or 5 days, and patients had to wear a catheter for several weeks after when they went home. So it was actually, here again, that's why most women didn't want to get any care, because when they considered that, they were saying, oh my gosh, no, we don't want that. But so when Olmsted developed this sling procedure, it revolutionized incontinence. And since that time, there's been many, many cases being done because this is an outpatient procedure. Patients can go home the same day, and generally they don't have to go home with a catheter for all that time. And what is done here, so this is the pubic bone, and this is a cartoon of the bladder. What we do is actually we take a small ribbon of mesh type material that's permanent, and we actually can thread it from the top of the bone all the way around the opening and back. And what it does is it creates a little hammock, a little sling around the opening, and that tends to stabilize the opening and also compress it a little bit when people are coughing or sneezing. And it tends to work in about 80 to 90% of patients. So it's fairly high efficacy, and so that's why for very young active people who are running around playing tennis or carrying grandchildren, this is a very good procedure. Okay, so with that, I'd like to kind of conclude with some take-home messages that urinary incontinence is currently underreported. It's a very common problem. And we now actually have a whole array of treatments that are reasonably effective. I wouldn't say that we could restore everyone back to when they were a teenager, but we certainly can improve their situation and their lifestyle. I do have to caution everyone that when you do have incontinence and you're thinking about undergoing treatment, it's very important that your physician and you consider the whole body to make sure that there's no other systems that are affecting this. Because it may be that if you take care of the other systems, your incontinence can improve significantly to the point that you don't have to do very much to your bladder. And also your goals, your personal goals as to what you want out of the treatment is very, very important. Because there has to be a very good communication understanding between you and the physician. Sometimes patients say, well, oh, I have incontinence, and the physician is interpreting this that, oh my gosh, this is really bad, we have to do surgery and take care of it, when the incontinence itself may not be that problematic for the patient. And there, what has happened is that there's been a miscommunication and patients end up with more treatment than what's necessary. Or it could be the vice versa, that the physician thinks that it's not a problem when it actually is very, very debilitating. So it's very important for you and the physician to have a very good understanding and set very realistic goals. Because even though we have good treatment that can help you improve, they're not perfect. So the goal has to be outlined fairly clearly. Good. I'd like to thank you for your attention, and I'm going to open this session up for questions. And I'm happy to go back to some of the slides if you want to look at it and ask more questions about that. Yes, I'll take that. Thank you.
On the sling procedure, is there a possibility that mesh could become dislodged and travel somewhere else into the body?
Oh, that's a very good question. So the sling, well, I'm going to answer your question, and then I will explain that there's been controversy about this, and I'll explain to you all what kind of the controversy is. The question was that does the sling material migrate to other parts of the body, or can it become dislodged, right? So the sling is actually, it's made of a non-dissolvable material that, and it's woven such that it's kind of like a mesh. Okay, there's holes that are visible. You can actually see them, and it's a little bit stretchy. What we do is actually we just wrap it there, and we don't actually tie it up or suture it. It's just placed there. What happens over the following 2 months is that the cells surrounding this mesh will start to grow into these holes. So to basically embed this material around the bladder neck. So that's why it doesn't migrate at all. And this mesh is similar to the meshes that are being used for hernia repairs in other parts of the body. So it's not like it will dissolve into small pieces and kind of travel through other parts. It does stay in that area. The controversy recently with the mesh is that, as I showed you that slide about the sling, how it became very, very popular in the late 1990s, and there's lots of cases done. It was highly successful. So people thought, oh my gosh, this material is very good. Why don't we use it in other parts of the vagina where we need materials to reinforce the tissues? And so companies started to design procedures where large pieces of the same mesh was put into the vagina all over the pelvis. And these procedures also became very popular in the past 10 years. And what happened was that gradually they started seeing long-term side effects where the mesh caused a lot of scarring or pain or discomfort with activities. And it got to the point where the FDA last year actually issued a warning that these kinds of side effects were happening and that we have to be more careful with the rampant use of these meshes. So that's where you see that controversy. However, that warning was because of these other types of usages of the mesh. If you just look at the data on the sling itself, you do have these incidents, but the incident of these things happening is much, much lower. It's a tenth of what happens when you use it for other parts of the vagina. Oh, you're welcome.
You mentioned for the sling procedure that you could go home the same day, but what is involved when that is put in the vagina?
Okay, so if you're just having the sling procedure alone, if that's your only problem, so as I mentioned, you can't take the body as one, it's a whole thing. Very often people have prolapse of the uterus and other things, so then the surgery becomes more. But let's say if you happen to be a very lucky person where you only have an isolated problem, we just do the sling. It's actually, the reason why it's adopted widely is because you don't need a big incision. You need, what is done is 2 tiny little incisions kind of above your hairline at the pubis, and then one inch incision inside the vagina. And we have these very special needles that allow us to thread this mesh. So the procedure itself is usually about 30 minutes under anesthesia. So, depending on your surgeon, anywhere from 20 to 40 minutes, I guess, that range. And when you wake up, there's no giant incisions. That's why the pain issue is not a giant one. You may have a little bit of vaginal spotting from the vaginal bleeding. Generally, we keep patients in for a couple hours of observation just to make sure they're doing okay. They go home, and in a couple of days, they're able to drive, but not exercise. So no heavy exercise for about 1 to 2 months.
And what kind of anesthesia?
For that, it can be general or it can be spinal. Yeah, it can be epidural. So we don't. It's just depending on the anesthesiologist's preference. Yeah. The procedure is so short that even if you have general, you're not getting a lot of the anesthetic in your body. So it's not that. Yes.
So how long does the sling remain effective?
That's a really good question. So, yeah, how long does the sling remain effective? So the mesh itself is non-absorbable, so it remains in your body forever. It's not going to get chewed up by the enzymes in your system or anything like that. So theoretically, it should last decades. But however, though, we have no ability to verify that. First of all, because the procedure started in 1995, so we only have like about 15-year data so far. So we haven't carried it out to 50 years from now. And the second reason why we have difficult time even verifying for more than 10 years is that patients don't like to be followed year to year. They move around or they don't want to be contacted. So if we start out trying to follow 500 people, by 5 years, we're probably only going to have like 70 patients. So we don't really know the true number. But there are some small studies where they've attempted to follow groups like 100 people. The one I know followed these people for about 7 years, and they found that to have similar efficacy as what it was started out. Maybe dropped a little bit by 5%, but because the numbers are so small, it's hard to know for sure. Yeah. Yes.
I'm wondering if you diagnosed stress incontinence. I'm guessing that stress incontinence could come intermittently, and maybe overactive bladder would be something more chronic.
I mean, you're correct in both ways. So stress incontinence can be intermittently because your body does change. For example, it may be exacerbated when you've gained 20 pounds, and then later on you lose it. You might not be as severe, and so therefore you're not being affected by it that much. or there may be times in your life when your pelvic floor muscles are more healthy and you're exercising more, so then the stress incontinence will be better. As well as the overactive bladder, it can wax and wane. Right now, we don't have a good handle on who's going to get better and then go relapse, or how long it generally lasts, because it's very difficult to study that. We have to actually follow a population for 5 to 10 years and document every month what are the symptoms. And that requires a nationwide kind of study, multi-center study that would probably cost millions and millions of dollars. And currently we don't have that ability to fund those kinds of studies. But I have to tell you that I practiced in this area for 15 years, and even in the 15 years, I've observed patients where they have waxed and waned, they've gotten better over time. And then again, something happens, maybe they have a back injury, it comes back again. Or if it's related to an infection or chronic inflammation, the inflammation dies down and they get better. Yeah. Oh, you're welcome.
You didn't mention the Kegel exercises at all. You mentioned them up there, but you didn't say, how do you do a Kegel exercise in the right way?
Yeah, it's very hard because the pelvic muscles aren't like your finger, the muscles on your hand where you can actually observe and you can tell it directly, oh, bend over this way, bend. You can't be, you're not aware of what they're doing, actually. They're just constantly doing their thing, essentially. It's kind of like your intestines are moving, but you can't tell it to do whatnot. So generally what's taught is that you kind of, when you're trying to urinate, you kind of use your muscles to stop it. That's kind of the motion. But even if you do that, it's not for sure that you're actually doing a Kegel. Because so often when I'm doing a pelvic exam and I put my finger in the vagina, I ask the patient, well, can you contract your pelvic muscles? I think half of the time they're not doing that. They're actually pushing everything out. So you may be doing the wrong thing. What we usually do is for people who really are motivated and really want to do the Kegels well, we actually send them to spend an hour or 45 minutes with our physical therapist, who actually specializes in pelvic floor exercises to teach the patients how to do it correctly. Another way is actually those vaginal cones that I showed you, because once you put the vaginal cones in, if you aren't contracting the right set of muscles, it will fall out. And so if you're actually pushing when you're doing the Kegel, then the cone will fall out. So that's how. Yes?
Following that, does that mean that the vaginal cones and Kegel exercises are the purview of physical therapists, or does one go to see a urologist? Or?
Oh no, you don't need to have that kind of highly specialized, referral to get to the vaginal cones. Actually, you can actually talk to your gynecologist or your family practitioner. In fact, I tell my patients, just go on the internet and they have them. You can just purchase it on your own. It's easy enough. There's a kind of mail order. There's different companies that make them, and you can try them yourself. If you don't feel confident, you can ask your gynecologist to refer you to a pelvic floor physical therapist for a session or two to kind of learn.
Is a vaginal cone similar to, I remember 20, 30 years ago hearing about something called Benoit balls that would be inserted into the vagina.
Yeah, it's similar, same kind of idea, yeah. Yes?
What about the relationship with bladder spasticity to fibromyalgia or some of those kinds of?
That's a great question, and that kind of falls into that kind of big unknown, giant pool of hypotheses. So the question was, how about the relationship between fibromyalgia, irritable bowel symptoms, bladder pain symptoms to these kinds of conditions that we talked about today? We don't really know, but there is some evidence that people who have irritable bowel fibromyalgia do have bladder symptoms. The current hypothesis, and we don't have concrete evidence, and it kind of comes from studying animals and the innervation, the pelvic nerves of the animals, is that there's some crosstalk between these nerves. They reside in a very close area. They almost have the tracts that are adjacent, and there's like a web of nerves that sit in your sacrum. So it's possible that the nerves are cross-talking. So the nerves that are being affected by the irritable bowel could be connected to the nerves that are innervating the bladder. And so therefore, if one set is irritated or kind of upset, the other will manifest in a similar way. So that's kind of the current hypothesis that we're working on. Yes?
Does the same stand for someone who has kidney disease as well as rheumatoid arthritis, or one or the other?
No, that would be a different mechanism. Yeah.
For both of them.
Yeah. And there you're talking about a more like an immunological issue.
Right.
So it's attacking the kidney and the other system. So it's not a nervous kind of nerve type issue. Sorry, here's a question.
If one has overactive bladder just at night, is it because when you're in that reclining position that your bladder is being in a different position?
You know, that's actually a very good hypothesis. We don't know that. But I do know from my patients that when they're lying down, they tend to put out a lot more urine. And so at night, they're getting up a lot to urinate. And I have spoken a lot about this to my internist friends. And it appears that when you lie down, there's two things that occur, probably a lot of things, but one thing is that for a lot of people, they've been standing all day, then the fluids tend to pull down into your legs, and that's why people get slightly swollen legs at the end of the day, and then when you sleep in the morning, they're better. So there's a lot of fluid that goes into the legs, and when you lie down, all that fluid tends to come back, and it goes into your kidneys, and then your kidney wants to put it out. And so that's one thing. And another thing they've suggested is that in a lot of older patients, their heart muscles aren't pumping as well, efficiently, because either they've had a heart attack or the muscles are just a little bit weak. So then when you're standing, it's very hard to pump all that fluid back up and into the kidneys. But when you're resting, lying down, the pump doesn't have to pump against pressure, so it's much easier for the heart to circulate all that fluid back to the kidneys and put out the urine. So a lot of patients that have these kinds of conditions are urinating more at night. So that may be one reason. But these are kind of just hypotheses and observations. We don't really have concrete evidence that it's what's really happening. Yes, back here.
The sling fails, within months or years or whatever. What is the more aggressive procedure, or do they just redo it? Is there a procedure that holds it up higher, or?
Okay, that's a really good question, because that is starting to happen. We're starting to see these people. The question is that if the sling fails, what is done next? Okay. It depends on the situation. At that point, we probably will do an evaluation to see how much muscle function is left. If it's not that, if the muscle function is not adequate, some of us would actually recommend repeating the sling, doing another one, slightly tighter. Of the mesh type, or there are some people that will still do the traditional way of using your own tissues or like a cadaveric fascia to create the sling. Thinking that with the rationale that, okay, maybe the mesh type sling didn't work because there was some issue with the compatibility with you and the material, so why don't we use a different material? So most people would offer repeating the sling or doing the bulking agent injections for that. The risk of redoing the sling is that what you're doing is making that area even tighter, so it might tip you into not being able to urinate as well. So you may have a little bit of retention, and that can tip you into a different set of problems. So there is a little bit of issue with that.
Maybe one more question?
Yes, sir.
How do you determine whether a pessary is appropriate or a sling or vaginal cone or whatever?
Oh, that's a really great question, because I go through this every day. Patients ask me that. Well, it depends on how, what your general philosophy is, how you like to approach a problem. Even though I'm a surgeon and I love to operate, I'll operate any day. I've been in this business long enough that I have actually seen some of the issues with surgery, because anything that we do currently is nowhere near as good as nature gave us. If you do a surgery and you wait long enough, you will see side effects coming from that surgery, regardless. There's always unintended consequences. So my general philosophy is to try for the conservative things first and see where that takes you. And there it's just a trial and error. We try, and there's nothing being lost. You fit somebody for pessary, let them take it home for a couple weeks, try it out. If it works, great. If it doesn't, you move on to the cones or whatever. And when we've exhausted the conservative methods, then we move to surgery. That's generally my philosophy. But having said that, I recognize that that's my own philosophy. There are people who really dislike the having something inserted into the vagina, and they want to move straight to surgery. And I think as long as they understand that there's some risk to that I'm okay with that. So that's kind of generally how I counsel my patients. Okay, great. Well, so I'm happy to stay for an extra 5 minutes or so if people have extra questions. If not, thank you very much for your attention.